Our first segment, we're going to review the adverse events associated with hematologic malignancy treatments. And we'll start with a case, and I'd like to turn it over to Patrick to open up the case.
The first case we're going to be talking about today is a first dose daratumumab. The patient walks in at 9:30 late for their 9 a.m. appointment, and only routine labs are drawn. At 10:15, the medical team approves the treatment. At 10:30, the RN gives the pre-meds of methylprednisone, acetaminophen, diphenhydramine, and montelukast. At 10:45, the daratumumab comes to the floor and is mixed in 1 liter and arrives at the bedside. Infusion is started at 50 mLs an hour. The patient has rhinuria, but it goes unreported. At 11:45, the vital signs remain stable and the rate is increased to 100 mLs an hour. At 12 p.m., the call bell goes off and coughing could be heard from the nursing station. The infusion is immediately stopped and providers called to the floor. The patient is red, diaphoretic, hypertensive at 160/90 with a heart rate of 120 and a pulse ox of 89%. IV diphenhydramine, methylprednisone, and a nebulizer is given. At 2 p.m., the patient is back to baseline and the infusion is resumed at 50 mLs an hour, and the patient tolerates it well. And the rate titration continues without any more problems. 5 p.m., due to the closure of the infusion center, the infusion is terminated and unfortunately 625 milliliters is wasted.
Oh, thanks, Patrick. I think that's a great way to open up the discussion about this medication and side effects.
Yeah,
AJ?
I think this is, daratumumab is a very exciting new treatment for the treatment of myeloma. It's an anti-CD38 monoclonal antibody. And a lot of our colleagues treating lymphomas have had rituximab for a long time, and we've been looking for such an antibody for myeloma. And it's not until November of 2015 that we had this drug approved. So while it's, currently it was initially approved for relapse refractory myeloma, but based on Castor and Pollock studies which were just published in New England, it's now moved into first relapse. And I mentioned that because the use of this drug is going to keep increasing. And maybe initially it was concentrated at academic medical centers, but this is going to be deployed widely across the community. And it's going to be incumbent on nursing team who actually administer these drugs on a day-to-day basis to really be comfortable with it. And so this case highlights a couple of issues. We know in the best case scenario that this drug will take pretty much the entire treatment day at most cancer centers, which are open 9 to 5. And so when the patient shows up late, we're already starting off late, and it sets us up for failure. And so it's really important when scheduling patients to remind them, please show up on time. The next thing is that especially in clinical trials where you absolutely need to have labs checked and resulted before you can start the drug, again, if you're starting at 9 a.m. and expecting that, you're immediately adding more time. So in patient situations or in hospitals where labs need to be drawn, we can consider having the patient come the day beforehand or even several days before, getting all the routine labs drawn, and so that as soon as the patient arrives, we can get the drug going. An important consideration in the lab testing is typing and screening, because daratumumab is an anti-CD38 antibody, and CD38 is expressed not only on myeloma cells, which is why it's used, but it's also expressed on red cells. So once a patient gets dara, it can be very difficult to do a type and screen, and so it's very helpful to have that type and screen sent pre-dara so that that blood bank at least has a baseline specimen for that patient. And one way to do that is, so at Mount Sinai, we've incorporated type and screen into our order sets so that every first dosed anti-CD38 patient is going to automatically have a type and screen sent. And also the blood bank is notified electronically that this is a first dose DARA, so to expect they're going to have issues potentially typing this patient going forward. As we know, for chemotherapy or biotherapy, immunologic therapy, we need to have informed consent. It's great to make sure that that's already in the chart. Notify pharmacy as well that this is a first dose DARA so that they can be all hands on deck as soon as the patient arrives. And as we talked about, getting all those labs ahead of time. As Patrick alluded to as well, in this case, the pre-meds were given. However, the time interval between the pre-meds and start of drug was very short, which sets the patient up for an infusion-related reaction very early into the process. And to that point, we know that 50% of patients will have an infusion reaction during the first dose of DARA. And most of the time, those are mild, what we consider grade 1 and grade 2. Could be something like runny nose. In this case, the patient did have that, but didn't disclose that. It can be a little redness or erythema. But this patient had more severe reactions. And the question is, could earlier pre-medication relative to the start of drug have minimized some of that? it may not have been eliminated completely, but perhaps the severity and the timing could have been affected. So, and that kind of highlights when nurses are starting the drug to really educate the patients to tell them of anything new that's happening so that the nurse can help assess the severity. And then the last thing is, this is, as we know, novel therapies are not cheap. And in this case, over half the bag, it's a liter bag of drug, was wasted. And in a setting where there's a time pressure of that 9 to 5, intervention or change that some hospitals are doing is splitting that 1 liter into 2 days so that you have 500 ml bags back to back. And that way, at least if you run into these kinds of issues, and keeping in mind that while a liter is not necessarily a big deal for all patients, but for an elderly patient with renal failure, cardiac failure, giving a liter over a day may in itself be a problem. And so by splitting the dose, that's another way of completing the drug. So I think this is a great example of a very important therapy for myeloma, but nurses can have an enormous part of multidisciplinary management that includes interacting with the medical team, pharmacy, patients, blood bank, and it's not just the physician writing the order and saying, give the drug. So it really highlights the importance of nursing in oncology care.
Oh, thank you. I mean, that's a great example of a new drug and how we really need to be paying attention to sort of a newer set of rules and how to administer it. Before we go on and talk about maybe some other new drugs, what else is new in multiple myeloma with regards to new drugs that may require kind of the similar attention?
Yeah, I think the other monoclonal antibody that was also approved in 2015 is elotuzumab, which is an anti-CS1 monoclonal antibody. CS1 is, again, preferentially expressed on myeloma cells. This drug is not approved as a single agent, but rather in combination with lenalidomide and dexamethasone for 1 to 3 lines of prior therapy. And so it also can have some infusion-related reactions, but at a lower rate than with DARA, and it also requires pre-meds. But I think it may be helpful because we have a lot of drug classes now, and I think sometimes like with antihypertensive drugs, when there's so many choices, it's hard to know what to do. Yeah. And especially if myeloma, while we see many patients at our cancer center since we're disease specialized, but in the community setting where you may not see that volume, but yet you're seeing all these drugs come in periodically, as a nurse it can be hard to keep up with that. And so one of the things we can go through is the drug classes that are currently available for myeloma. And so first, steroids are very important in all lymphoid and plasma cell malignancies. And it's interesting because we used to use high-dose dexamethasone, which is 40 milligrams daily for 4 days. And to convert that to prednisone, it's 200 milligrams of prednisone. So I don't think there's any other medical condition where we give over 200 milligrams of prednisone daily to a median age population of 65 to 70. And not surprisingly, it was a patient that actually asked for a randomized study to justify whether we needed to use that dose. And lo and behold, they were proved right that if you give, because we have so many other drugs, you can give weekly dexamethasone at 40 and minimize infectious risk by doing that rather than depulsing.
Very interesting.
Yeah, so steroids are a really important part of myeloma management because not only do they are plasma cell lytic, but they also are antiemetic, and they can minimize infusion reactions with the monoclonal antibodies. They're not myelosuppressive. But again, I think Patrick will probably have some insights into how patients tolerate these steroids and how to best take them.
What do you think, Patrick?
They usually don't very well. I always explain to the patients, you may not sleep tonight, there's insomnia, and there's always there can be like a crash like 2-3 days later. Gastritis, insomnia, little irritability, make sure the family's aware. People that are diabetic, they have to really be diligent about their blood sugar testing. Sometimes we need to adjust their medications. We have to send them to endocrine, things like that. And so that's stuff that needs to be handled and understood by the patients. So, because that's stuff that happens not in an infusion center, stuff like that. So.
And I think you alluded to the insomnia can be really helpful to take it in the morning, right, with food, because some of the doses of Dex will be at home. And I think steroids are interesting because they're one of the drugs where when we see our patients in clinic and say, oh, how's the treatment going? Are you tolerating it okay? Usually the patient will nod, yes, fine, and the family member is saying no.
Yes.
Because the irritability and the insomnia can actually wreak havoc on the home life. So I think, again, nurses can be very helpful in helping patients cope with those issues. So the next drug class, which is old, is conventional cytotoxics. This includes cyclophosphamide, melphalan, bendamustine, 96-hour chemos like DCEP.
How much are you using those? Are you using those less?
I think that, they're oldies but goodies. I think depending on resource, especially in resource-poor settings. I mean, we're talking about myeloma care in U.S., but globally there's very high use of these drugs because some of the novel agents haven't yet made it. But some of these drugs still are very effective, and we combine them often with these novel agents. So melphalan in particular, obviously high dose is used in transplant. But some of these drugs also come in oral, and I know we're going to be talking more about oral drugs, but again, in speaking about, the main toxicities of these conventional cytotoxic is the myelosuppression. And so for that, managing with growth factor support can be important. And maybe Patrick, you can talk about it. Maybe we've even had some patients self-administer.
We train them when we're at home. A lot of times I wind up teaching family members to administer, to make sure it's in the refrigerator, make sure you take it out for a little bit before you administer it. And also when they're in treatment and when we talk to them, we give them a little schedule. You could do this for 3 days in a row, come 2 days later for a value check to make sure that it's that your accounts have come up, things like that.
And there's also the new on-body pegylated growth factor, which again, as a nurse, you've probably had experience with that in terms of the importance, the benefit for patients.
Yes, especially the non-compliant patients. You're not supposed to give growth factor for at least 24 hours after the last chemo dose. This is an injector that actually you put on them, and it has like a little fiber, I believe, and it injects the growth factor. Pegylated growth factor about 26, 27 hours later, so that you don't have to worry about them not coming in the next day.
Technology.
I know.
I know, it's really
wonderful,
fascinating, and it works well.
A lot of people pay them a lot of money to come in too. They have to take a taxi, things like that to come in.
Right, so for any regimen where there's the as per ASCO guidelines, if there's more than 20% risk of severe neutropenia, we can justify the use of these drugs. And we can talk more about antiemetics because that's another management. But I think, so we've covered 2 drug classes, corticosteroids and conventional cytotoxics.
What about the IMiDs?
It's a great question. The IMiDs are very important,
Maybe we should say what IMiD stands for.
Yeah, so it's actually a very interesting story, immunomodulatory drugs. So thalidomide is the first one in this class, and it initially was noted, it was being studied in a patient for leprosy and was found to have some activity. And because of its anti-angiogenic properties, was then studied in myeloma. And it was a patient who lobbied for trying this drug in myeloma, and the dramatic response led to now $1 billion market for this drug class. And it basically was, thalidomide was the first generation, second generation is lenalidomide, and third generation is pomalidomide.
I have to tell you, and Sandy probably would agree, that those drugs are still tools that we use in myeloproliferative disease as well. And they're starting to come back because we deal with a lot of anemia, and that's one of their benefits in dysplasia and proliferative diseases. But go ahead.
I think the label has now extended and its use is beyond myeloma, MDS, MPNs, even Kaposi sarcoma. So the uses are just continuing to grow with this drug class. But I think the main toxicities that we need to be mindful of, because they're all very efficacious drugs, people probably, the first line of IMiD use in most myeloma patients will be lenalidomide. Pomalidomide is not indicated yet for first-line therapy, so it would be second-line or beyond. And thalidomide is also useful, and their side effects are basically a little bit, the unifying side effect for all of them is thrombosis, particularly in myeloma, where in combination with corticosteroids, the risk of thrombotic events is 20%, and that can be mitigated with antithrombotic use. Even aspirin, which we usually think of as an antiplatelet drug, but perhaps because of the endothelial impact of these drugs, antiplatelet drugs have been shown to be helpful.
Let's spend a minute on that, actually, because that's maybe one of the other side effects just to be aware of. What's your approach, everyone, with regards to venous thrombotic embolism prophylaxis in myeloma or more broadly? I mean, is it automatically aspirin, low doses of other anticoagulants? We have the newer anticoagulants. What do you think?
So I think it goes to risk-benefit question, and that's going to be patient-specific. So single agent IMiDs don't necessarily need a lot of additional prophylaxis. When you add corticosteroids, everybody at a minimum should be on aspirin. Obviously, one of the complicating things is what do you do with that patient who's already thrombocytopenic, and aspirin may be challenging. So there, we obviously encourage people to be very active. Then if somebody is at higher risk because of poor performance status, history of thrombotic event, combination therapy with anthracyclines, then we probably go beyond aspirin to either low molecular weight heparin or warfarin. Studies have shown that low-dose warfarin are not effective, so you either
Yes.
need to go
Yeah.
full
You
have to
dose
go.
or,
think that's-
or use a different class of drug.
Maybe one of the newer anticoagulants.
Yeah, so
NOACs.
the NOACs, the novel oral anticoagulants, as you know, they're not yet
I was
officially
just going to say,
indicated
can
for
we
this.
get that for that? Right, because
Right.
they're not indicated.
But
So
there's been meta-analyses in cancer that
Mm-hmm.
have been shown that they can be used safely. And again, it goes back to risk-benefit, the diet and drug interactions with warfarin offsetting,
Yeah.
some of the more traditional data.
We
just
just
as
have
you-
to convince, we have to convince the insurance companies that
Mhm.
they're
Yeah,
getting it
absolutely.
paid for the,
Yeah, no, that's absolutely. And I was just going to say, just
Lots
as you,
of time on the phone.
yes.
lots of time on the phone.
Lots
Yes.
of time on the phone.
And,
Yeah.
and as you raised, a lot of these patients are complicated. They have multiple comorbidities. They may have more than
Right.
one reason or multiple risk factors. So good.
And the other thing that fits into that is the use of erythropoietic growth factors,
Yes.
which we know that also can increase the risk of thrombotic events. So when somebody's getting an immunomodulatory drug with steroids, with an ESA, again, think about
Levels go
either
higher.
minimizing the use of ESA or therapeutically anticoagulating to prevent that. It's much easier to prevent a clot than to treat it.
Yes,
Yeah.
it's
Any other-
interesting. Well, I was going to add, in the MDS or the other heme malignancies using the IMiDs, we don't see a lot of the DVTs or the clots so much. And I think just adding the steroids, it's really
It's
the
probably
key of being more aware, I guess, of what they're taking. Concomitant meds, yeah, the multiple meds.
drugs. Yeah.
Yep.
Any other classes of drugs you wanted to mention?
Yeah,
Myeloma?
I think,
know there's
well,
more.
and then the other thing, just to complete the image, was
Sure.
just to be also mindful of the differences in myelosuppression amongst the three drugs. So
Mhm.
thalidomide tends to be the least myelosuppressive. Len and POM are more myelosuppressive and can require dose mods or growth factor support if indicated. And then the other thing is renal clearance is an important issue. So thalidomide does not require any renal dose mods. Lenalidomide does for creatinine clearances less than 60. And POM is, per label, can be used up to a creatinine of 3, but there's also data emerging that can be given in more severe renal dysfunction.
What do you guys tell people about neuropathy and GI side effects from some of the IMiDs as well? Do you run into that a lot?
Yeah.
Well, I tell them to tell us right away because a lot of times it could be stopped or minimized through either, I guess, talk to the doctor, dose reduction, or through drawing labs. Sometimes the patient's B12 may be low, or their carnitine may be low, and we could actually minimize it through just regular supplements that could actually be over the counter.
And you bring up important, actually, issues specifically for lenalidomide-associated diarrhea. There's been some studies showing that bile sequestrant can actually minimize that, and we've had dramatic improvement in patient symptoms with the use of that
Yeah.
drug.
Sandy, have you used that in CML patients ever?
What the
bile-
bile,
yes.
I have not.
I find the same for
With the-
medication-induced, loose movements. I think the bile acid sequestrations have a role
Yeah.
by a bulk effect, which is great.
Yeah.
Good pearls. Very
Yeah.
good.
So then the next and another big backbone drug class for myeloma is proteasome inhibitors. The first generation was bortezomib. Initially came about in muscle research, and went very quickly from bench to approval in about 8 years. And initially with relapse disease, but now used in frontline disease as well. Second generation carfilzomib, which is it's a different structure. Bortezomib is boron-based. This is an epoxy ketone, and it's an irreversible inhibitor. The dose-limiting toxicities of the two drugs are very different. Bortezomib is neuropathy. Carfilzomib is hypertension. And then most recently in 2015, it was a very busy year for myeloma. 4 new drugs were approved in 1 year, which is really great for patients. But the third PI that was approved was ixazomib. And so this is the first oral proteasome inhibitor, which is, again, great for patients. There's patients who are, for example, on dialysis. And so they're already spending 3 days a week in the hospital center. And then we're asking them to come in their free time for more chemo. And so there's now an oral proteasome inhibitor, which, again, has to be modified for renal function, but it allows patients to have, a meaningful quality of life. I think the most important unifying toxicity for all of them is the risk of shingles. So 20% of patients treated with a proteasome inhibitor can have shingles reactivate. Of note, shingles vaccine is not yet FDA approved for
I was
heme
just gonna ask
malignancies,
you
although
that.
it's under investigation.
Yes.
So our mainstay of preventing shingles in this population is prophylaxis of acyclovir. And again, because myeloma patients, 30% will have renal failure, those meds also need to be modified for renal function, acyclovir or valacyclovir. And then maybe Patrick can talk a little bit about the nursing issues, I think, with giving bortezomib and carfilzomib.
I think it's important with the bortezomib to talk to them about the injection sites, because it used to be IV, and a few years ago it became we were able to give it as an injection, and that decreased the chance of neuropathy.
And that actually is a very interesting story in and of itself, because as I alluded to, the dose-limiting toxicity was neuropathy, but when you give the same drug sub-Q, you change the pharmacologic properties such that the high Cmax, the max concentration, is lower, but the area under the curve is the same for whether you give it IV or sub-Q, and what matters is the peak concentration for neuropathy. So this sub-Q administration has really diminished the rates of neuropathy and GI side effects, but maybe you were alluding to what patients experience when we do sub-Q.
Because it leaves marks on their belly, on the area that they get injected. So I know it sounds simple, but a lot of them get upset, or because they don't know, because they go to the beach. Or somebody wanted to know if they could do it on the arm, things that we don't really think about when we're giving them their medication is,
It's a localized
them,
reaction, or is it a...
It actually, I don't know what it is, but it actually looks like a darker tone of skin.
Oh, okay.
Like
So
a little circle around it, and it stays for quite a while. And so they wind up having like discolored abdomen, and so I let them know ahead of time. We could always move it down to their leg if need be.
And you rotate sites.
I do rotate sites, and again, move it to like an area, like to their legs. Like if it starts getting too, if it starts looking kind of messy up here, we could do like the legs.
Do you ever go back to IV? Like, do patients say, I'd rather have it IV and take my chance of neuropathy?
No,
or
very
rare.
Yeah.
So we're having, again, what a great advance. We're having different conversations with the patients about different subtle and different toxicities for our newer drugs, and especially myeloma, where there's been such an explosion. I mean, I think, but these are really important things for people to know about now, and things to address as these drugs move into practice and become more widely used.
And I think we should also just mention that with carfilzomib, important nursing considerations when giving the drug are blood pressure monitoring, because, and this is a great drug of why I think nurses are so key. The schedule of carfilzomib is day 1, 2, 8, 9, 15, 16, which is twice weekly. There are newer data for once weekly. But as physicians, maybe we see the patient before day 1, or day 1 we write the order and then we disappear. And it's the nurses who are seeing the patient in each of those visits. And what can happen is that patients can get hypertensive. There is fluid built into this first dose of carfilzomib pre or post hydration. And for somebody who's getting hypertensive, gaining weight, maybe becoming short of breath, it may require modifying the schedule of the drug. There are also some studies suggesting maybe longer infusions may be better. In fact, it's required for higher doses, so it's again another very nursing important. If the carfilzomib is below, it's 20 or 27 milligrams per meter squared, it can be given over 10 minutes. The minute you go to higher doses, 36 or beyond, it must be given over 30 minutes. And it also goes into mildly emetogenic, so we do need to give additional chemo, antiemetic. So important nursing considerations for carfilzomib as well. And then
the heart failure too.
So
if they start getting short of breath quicker, if they find it harder to go upstairs, something like that, it could be the beginning of cardiac issues.
Do they go on oral, like diuretics, or just something that we monitor?
Yeah. I mean, things that you can also do to, the incidence of heart failure is low, but it's not zero. Studies are suggesting somewhere from 3 to 7%. And patients who are at risk are going to be older patients who have cardiac history, anthracycline use, uncontrolled blood pressure. And the things we can do is check a baseline ejection fraction for those patients, monitor the BNP, monitor their weight, monitor their blood pressure.
Avoid sodium.
Yeah, avoid sodium. Consult cardiologists or oncocardiologists, because it's a very unique skill set to monitor these.
And we have a very similar problem with some of the oral kinase inhibitors, where they have more than just the targeted therapeutic effect, but potentially an off-target effect, and hypertension can develop more subtly over longer periods of time. So,
and weight gain, right?
Sure. And so paying attention more to just basic things like the blood pressure. Yeah. Fantastic. As a springboard, you mentioned antiemetics. So what's new in antiemetics? Do we have any, I know I think the points we thought we'd talk about maybe olanzapine and some of the newer classes of antiemetics.
Yeah, I think this is one of my favorite things to ask students, residents, and fellows, because I think Anybody who's had a viral illness or any kind of GI can empathize with how debilitating even nausea can be, even though we say grade 1, 2, but if you're chronically grade 1, 2, that can have a huge impact on the quality of life. And again, a great role for nursing intervention. But I think it's important to think about, we have many drug classes to treat nausea, and it's one of the most preventable things. So we have,
We've come a long way.
yeah, I mean, literally the
since
classes of drugs are
ondansetron.
dopamine antagonists,
Right. Yep.
antihistamines, anticholinergics, 5-HT3 antagonists, neurokinin inhibitors, corticosteroids, benzos, and cannabinoids. And I think, so essentially we have 8 classes of drugs to treat nausea and vomiting. And probably the most kind of newer indications, so olanzapine, which is an atypical antidopaminergic drug, has now been approved for the treatment of nausea and vomiting. The second novel anti-drug emetic
Like
is,
the patch.
yeah, do you want to, have you
I
used
say,
the?
I
and working in
have.
acute
We've-
leukemia, Sandy, I know you
Yes,
probably
we
do.
use the patch. It's a, we put it on. It works for,
Remind me, this is which agent?
it's
Okay,
grenacitron.
so it's a grenade
Five-
patch.
Grenacitron,
yeah.
right, 5-HT3 blocker. So it just gets sub-Q, a patch for the week, and they keep it on, and
Fantastic.
it works beautifully in nausea so that they don't have to keep popping pills, because the last thing you want to do is take a pill when you're nauseous, right?
Yeah.
Yeah.
And this might
So
not be the
this
thing that's built
just-
into the orders, but maybe something that nursing or any of the team
Yes,
members
well,
notice.
if you think about, right,
Yeah,
if you think about it,
Yeah, particularly if your patient's at home and calling,
yes.
Yes.
and
Delayed,
they can't come into
come
the
into
hospital.
the,
yeah.
right,
delayed
Yeah.
emesis.
so,
Yeah.
right, so they could just put this patch on
Yeah.
their arm and off they
Have you
go.
used any of the other newer drugs, such as the aprepitant, the substance P inhibitor?
We have in the higher dose chemotherapies, like ALL patients. We've done that where they come in for specific regimens, outpatients, so they're able to get the 3 days or 3 doses. Plus, we can prescribe it as well as an outpatient. They get day 1 in the office, and then they get the 3-pack dose as an outpatient. So it works pretty well,
And I think it's
like
can be
long-acting.
exactly for the delayed emesis, which
Correct.
historically has been
Yes.
an unmet medical
Correct.
need. Other than steroids, there was really very little
Right.
approved for that. And have you used the longer-acting palanicitron for the 5-HT3 antagonists? Because it's another,
Yeah, that's another
Long
whole class. I
half-life,
have
so-
not, I'm not that familiar with that
because
drug, but
this
that-
is just, I think,
it's-
another tool in our
Yeah.
toolbox, right?
that we have
Because
to all,
when the delayed nausea can be very challenging to treat, and so when you're using especially high doses of platinum, those kinds of drugs, and particularly
Right.
solid tumor colleagues probably
Right.
use them more.
I think,
correct?
yeah, hopefully we're moving a little bit more towards non-chemotherapy based regimens
Correct.
for
Right.
acute leukemia and even
Right.
chronic leukemia. So, but also good points. Fantastic.
Yeah.
Yeah.
So we moved a little bit into the area of more acute and more intense toxicities. I think building on the great review you just did for myeloma drugs, think about some of the broader categories like immune therapies and the toxicities there. They may be newer for people to recognize because they're not necessarily approved or not everyone's familiar with them, but
Right.
things like the bispecific antibodies and even CAR T-cell therapy,
Right,
which
CAR
is
T.
clearly building in its experimental data and will become, I think, a great tool. But that has a whole yet another set of toxicities. I mean, our inpatient team has experience in many centers as well, where you actually have quite intense immune-related phenomenon of cytokine release syndrome, which can mimic symptoms like edema, heart failure,
Right.
the anaphylactoid reactions you see with an
Respiratory
antibody.
distress.
It's hard for us to separate. What's a neutropenic fever? What's a cytokine release syndrome? What is a drug effect? And then blinatumomab is an ambulatory drug, which is given by infusion, and patients are in the hospital for some of it, but out of the hospital for
Yeah.
others. And there's a lot of overlap. Any other thoughts you guys have on those drugs? And
Well,
use in myeloma? I mean, we use them in lymphoid malignancies. So
Yeah, I think, I like to think about these in terms of classes because, so we've talked about the naked antibodies, if you will, right?
Yes.
So things like Dara, Elo, rituximab, which main thing is infusion related. But checkpoint inhibitors, which are technically naked antibodies, but have a very different,
Activation.
not only have, they have relatively minimal infusion issues, but then the autoimmune complications really are important. And again, I think nurses who are at the bedside will probably be the first line of defense from preventing and monitoring
Yeah.
these. And those common ones, the organs that need to be paid attention to would be lungs, liver, gut, and skin.
central nervous
But
system too.
CNS as well, but
Yeah.
so we have 2 FDA-approved checkpoint inhibitors now, nivolumab and atezolizumab, which is a PD-L1, whereas nivolumab is a PD-1 inhibitor. In myeloma, we have both of those drugs in clinical trials. We have some preliminary data that they may be able to overcome lenalidomide and pomalidomide refractory disease. Also some studies in bortezomib refractory disease. So a very important area of research because PD-1, PD-L1 is aberrantly regulated in myeloma. So I think we're going to see more of those. But then the third drug is the bispecific, which
antibodies.
you alluded to.
Yeah.
Then the fourth drug class is antibodies that are conjugated. So probably the best example would be rituximab.
Yes, in the lymphoid malignancies. And,
Right.
and we've had a number of drugs come through in myeloid disease as well, conjugated antibodies, starting with gentumab, probably as the first. But
Right. And then I think the CAR T you alluded to, the cytokine release.
Yeah.
And important, and again, it's probably a very few specialized centers so far,
Yes.
but the pathophysiology is also interesting, right? The IL-6 mediated problems. So the anti-IL-6 drugs like tocilizumab are being used extensively to
Yes.
manage those
as an
side
antidote,
effects.
literally.
Right, yeah.
I just think it's important to point out that some of the drugs that are being more widely used, like blinatumomab,
Yeah.
can mimic some of the things that we're seeing more in the inpatient unit and are trying to better describe and better manage, like CAR T-cell toxicity.
And in
So-
fact, it's kind of interesting to put those together because CAR T has to be patient-specifically engineered, and there's that manufacturing
Yes.
downtime, whereas the bispecifics have the
Off the shelf.
off-the-shelf feasibility, but then they both share some of the same side
Yeah.
effect profiles. So, yeah, I think it's going to be an increasingly nursing-intensive world of immunotherapy.
Yes.
What other supportive care and toxicity management topics haven't we discussed? Maybe infection prophylaxis or
Yeah.
drug-drug interactions? And there's definitely some other things to consider. One of the things I think is most important is prophylaxis in the neutropenic patient and what we know is very excellent neutropenic prophylaxis, but how does that interact with the medicines that we're giving them for treatment? TKIs is a big example. Other chemotherapies are clearly going to be examples. So I think we obviously need to run the medication list and be careful about as a multidisciplinary team, the prescribers, practitioners, and physicians, and even RNs, chiming in and helping patients navigate.
Yeah, I think myelosuppression management is very interesting. We, as Patrick alluded to earlier, we now have the on-body growth factor for long-acting. We now have a generic
Right, yes.
filgrastim, which is great for patients who may have issue. I'm sure you guys
Insurance.
struggled with those prior authorizations for
Quite,
filgrastim.
yeah.
So it's good to have a generic version for patients that's low cost. ESAs can still be used in different malignancies. And there's also a lot of work being done in the platelet world of thrombomimetics. And most of those indications are still for thrombopoietin mimetics, which are mainly for ITP at this point. But it'll be interesting to see as future research goes on whether there might be a role for that in chemotherapy-induced
Exactly.
thrombocytopenia.
There's some nice research in acute myeloid leukemia, being able to minimize the transfusion support that is going to be still expected with our conventional regimens by using those thrombopoietin mimetic drugs. Again, not standard therapy, but coming soon. So better supportive care still on the horizon.
And probably two other things relating to myeloma. One, you brought up with infections. Unfortunately, when you have a humoral immunity problem with the disease, recurrent bacterial infections is part of the manifestation. And for patients who are hypogammaglobulinemic, a consideration can be IVIG, which is typically initiated if somebody has, say, more than 3 to 4 infections in a given year. And then the other kind of interesting drug, which is also, the bones are very important in myeloma, so bisphosphonates are indicated in the treatment of myeloma, even in patients who don't have lytic disease at baseline. There was a study in UK that showed that the use of zoledronic acid improved overall survival by 6 months and relative to those who didn't get it, and these were all patients with symptomatic myeloma. But the other drug in that bone modulating is denosumab, which is historically was for solid tumors, but then it got FDA approval recently for the treatment of refractory hypercalcemia. And at this year's International Myeloma Working Group conference, there was a study comparing zoledronic acid and denosumab for non-inferiority, and it was non-inferior, and there was even a suggestion of PFS prolongation. Obviously, that needs to be published, but denosumab is definitely a drug that we can use in any tumor where the hypercalcemia is really refractory to standard therapy, with the important consideration the black box is profound hypocalcemia. So intervening early with calcium and vitamin D repletion the minute the calcium starts normalizing.
And it's nice because it's just a sub-Q injection.
Yeah.
Yeah.
It does.
It's
It makes
easy.
it easier for the patient.
And less renal
Yeah.
issues too. So again, in
Yeah.
myeloma, important consideration.
Well, myeloma is really just given us a
Booming.
whirlwind tour of new therapies and supportive care, and set a great example. Any last comments? Anything else? I mean, we sometimes get asked about non-traditional tools that patients can use or other things.
I think the one other class we didn't mention is panobinostat, and it is it's
getting back to
which is
therapies.
worth mentioning because
Sure.
it does have other heme malignancy. The class has a heme malignancy indication. So panobinostat is a pan-HDAC inhibitor, and it is also FDA approved for the treatment of myeloma in at least 3 lines of prior therapy in combination with bortezomib and dex. It's oral, and it's indicated the 20 milligrams 3 times a week is the official indication. Huge nursing implications for this drug because
Diarrhea.
in this
Diarrhea.
clinical trial where bortezomib and dex and placebo was compared to bortezomib dex pano, while the PFS was extended, and that's the basis of the approval, the rate of grade 3-4 diarrhea went from 8 to 25%. And that is grade 3-4 diarrhea. It's easy to say, but it's terrible to live with.
Right.
I mean, we're talking continuous liquid
Yeah.
stools.
Unable
I'm
to
sure you
leave the
guys,
house,
what are
you know,
your
yeah.
go-tos for helping patients manage with these?
Preventative, if they look for patterns, if diarrhea is worse the day after the pill, take loperamide before.
In fact, I think the
Do you have-
panobinostat pack comes with
Oh, does it?
preventative
Okay.
antidiarrheals.
And if
because
not,
it's-
we,
Yes.
there's other things that we go to. Even opium tincture sometimes will help. Sometimes we have to get to that level because it's, people, they can't go out to dinner sometimes. They can't do, live their life. Quality of life kind of can be very rough. With,
Do you set them up with a nutritionist, like have
Yes.
them see some like multidisciplinary kind of
Oh, yes,
things
always.
that they
Yeah.
change diet or?
And
eat
the
better.
other drug in this class, verinostat, is approved for the treatment of cutaneous T-cell lymphoma. So again, these drugs are being used in other tumors and work being done even, I think, in MDS,
you-
AML,
yes.
right?
Yes.
with
Yes.
Yeah.
The HDACs.
And
Yes.
we occasionally run into what could be significant diarrhea with some of the TKIs, like
Yes.
bosutinib, for example,
Yes.
where patients may need the same kind of management approach. They're warned, they're given preventative strategy,
Yep.
they're armed with antidiarrheals at home.
We start them at a different dose to work
Exactly.
our way up
Yes.
to see how well they tolerate it so that they
Yeah.
don't get discouraged and don't take the medicine.
I know.
That's a huge
That's
point.
a huge thing.
Yes.
Yeah.
Dose modification,
Yes.
interruptions, if it's severe,
Yeah.
because
Yeah.
patients may just not even want to continue the treatment
Right,
if they're
'cause
not
it's
allowed
so
to recuperate.
miserable, right.
I think I have to recognize the label and the studies that we do that, obviously good science and tell us what the approved dose and how to manage, but anecdotally and experience builds, and I think that's the case with TKIs and obviously a lot of the infusional drugs as well, or injectable drugs where you may have to start low, you may have to dose reduce to get through therapies.